Hematologic conditions and management in cardiac surgical patients. We see a lot of hematological conditions, and the most commonly seen condition in any medical or surgical patient is anemia. Anemia can be divided according to the size of RBCs, and it could be microcytosis, macrocytosis, or normocytic anemia. Microcytosis its causes of low MCV are iron deficiency, thalassemia, sideroblastic anemia, and anemia of chronic disease. Macrocytic anemia is of high MCV due to B12 or folate deficiency, which leads to megaloblasts, sideroblastic anemia, alcoholism, anti-metabolite medication such as azathioprine, liver disease, myelodysplastic syndrome, and phenytoin. Normocytic anemia could be acute blood loss or hemolysis. And treatment of anemia is if the patient is symptomatic and very low hematocrit, elderly, or one with the heart disease. Obviously, in the cardiac surgery, we need to transfuse the patient with low hemoglobin. The cutoff value is between 7 and 8, and because they will be symptomatic if hemoglobin goes less than that. So the options available are packed blood cells. So in the microcytic anemia, the etiology is iron deficiency, and the chronic disease, sideroblastic anemia and thalassemia. So we have to do the iron studies, and the ferritin will be low, and high ferritin is seen in sideroblastic anemia, and normal ferritin, normal iron, high iron in sideroblastic anemia, normal iron in thalassemia. In iron deficiency, low ferritin is extremely specific for iron deficiency anemia, and higher percentage of the patient have increased ferritin. In the chronic disease, the serum iron is low in circulation, and because the iron is trapped in storage, so that is why ferritin or stored iron is relatively elevated or normal. Sideroblastic anemia, there is only one form of microcytic anemia in which the circulating iron level is elevated. So the treatment of microcytic anemia is to replace the iron. Chronic disease, correct the underlying condition, and sideroblastic anemia, some response to B6 or pyridoxine replacement. Thalassemia trait is not treated. Beta thalassemia major is managed by chronic transfusion lifelong. Iron overload is managed by deferoxime or iron chelator. Microcytic anemia is caused by pernicious anemia, pancreatic insufficiency, dietary deficiency, Crohn's disease, blind loop syndrome, diphyllobotum latum infection, HIV, and folate deficiency is caused by dietary deficiency of folate, goat milk, psoriasis, and sulfur drugs. Alcohol can give rise to microcytic anemia and neurological problems. Diagnostic test: megaloblastic anemia, increased LDH, decreased reticulocyte count, hypercellular marrow and macrovalocytes, and increased homocysteine levels. B12 and folate deficiency are identical hematologically on the smear. So the treatment is folate replacement and replacement of the B12. The next group is hemolytic anemia. All forms of hemolysis can lead to sudden decrease of hematocrit, increased levels of LDH, and decreased haptoglobin levels. Then we have sickle cell disease. It's a type of anemia where there is abnormal blood cells, could give rise to vaso-occlusive crisis caused by hypoxia, dehydration, infection, and cold temperature. Other manifestations of sickle disease include bilirubin stone, gallstones, osteomyelitis, retinopathy, strokes, avascular necrosis of femoral head. So diagnosed by peripheral smear, and the treatment is oxygen, hydration, analgesia, and manage the white cell count, folate replacement, pneumococcal vaccination, and hydroxyurea prevents recurrence. Hereditary spherocytosis again is diagnosed by low MCV and negative Coombs test, increased MCHC, and treatment is folic acid replacement and splenectomy. Glucose 6-phosphate dehydrogenase deficiency is again recessive disorder common in Mediterranean men with sudden anemia. Diagnostic test G6PD levels would be normal after hemolytic event, so best test is Heinz bodies or bite cells. Aplastic anemia is of unclear etiology, and pancytopenia are caused by radiation drug effects like sulfaphenotone, SLE, PNH, and infection, B12 and folate deficiency, and thyroid inhibiting medications. Presentation is fatigue, infection, and bleeding. Treatment is blood transfusion, allogenic bone marrow transplantation, and the patient is too old, anti-thymocyte globulin, cyclosporin, and tacrolimus can be used. Polycythemia vera is another condition which we commonly see. And it is unregulated overproduction. Polycythemia vera is unregulated overproduction of all three cell lines, but red cell overproduction is more prominent. And there is maturation in JAK2 protein. Patient presents with headache, hypertension, fatigue, splenomegaly, bleeding, and thrombosis. Diagnosed B12 levels are elevated and diagnosed by JAK2 mutations. Treatment is phlebotomy, hydroxyurea, allopurinol, and antihistamines. Essential thrombocytosis is markedly elevated platelet count above 1 million, leading to both thrombosis and bleeding, and reaction to other stress such as infection or cancer. Treatment is hydroxyurea. Aspirin can be used for erythromelalgia. Myelofibrosis is disease of older person and diagnosed with a teardrop cell, thalidomide and lenalidomide and TNF inhibitors increase the bone marrow production. Leukemia. The acute leukemia patient present with the signs of pancytopenia, and there will be increased white cell count and infection, and the blood smears will show the blast cells. Myeloperoxidase is the characteristic of acute myelocytic leukemia, and the treatment include all trans-retinoic acid and intrathecal chemotherapy. Chronic myelogenous leukemia, they present with pruritus, splenomegaly, and CML can also present with high WBC on routine exam. And diagnostic test is low alkaline phosphatase score, and the treatment is tyrosine kinase inhibitors, and only a BMT can cure CML. Myelodysplastic syndrome is a pre-leukemic disorder present in older patients, present with fatigue, infection, bleeding, and splenomegaly. and diagnosed by increased MCV, nucleated red cells, ring sideroblasts, and severity is based on percentage of blast. Treatment is transfusion, erythropoietin, and lenalidomide. Chronic lymphocytic leukemia is abnormal proliferation of the B cells. CLL occurs over the age of 50 and 90. Many are asymptomatic at presentation with only markedly elevated with white cell count. The most common symptom is fatigue, lymphadenopathy, spleen or liver enlargement and infection. WBC count is usually at least above 200,000. Half of the patients have hypogammaglobulinemia. Treatment of CLL for stage 0 and 1 there is no treatment. Stage 2 and 3 where there is hepatosplenomegaly anemia, and stage 4 thrombocytopenia are treated with fludarabine, and rituximab can also be used. Lymphomas could be Hodgkin lymphomas and non-Hodgkin lymphoma. Non-Hodgkin lymphoma is the proliferation of lymphocytes in the lymph node and spleen, and they present with the painless lymphadenopathy may involve the pelvic, retroperitoneal or mesenteric structure, and B symptoms of fatigue, weight loss, night sweat. A diagnostic test is excisional biopsy, and treatment is cyclophosphamide, adriamycin, vincristine, prednisolone. Hodgkin's disease are diagnostic B symptoms staging, and there may be Reed Sternberg giant cells. Treatment is adriamycin, bleomycin, vinblastine, and dacarbazine. Myeloma is abnormal proliferation of the plasma cells. These plasma cells are unregulated in their production of useless immunoglobulin, that is usually IgG and IgA. IgM is separate disease called as Waldenstrom macroglobulinemia. They are present with hyperuricemia, anemia, and renal failure, and the X-ray of the bone show lytic or punched out lesions. And laboratory investigation may show hypercalcemia. Benz-Jones protein beta-2 microglobulin levels correspond to the severity of disease. Smear show roller formation and elevated VU and creatinine. Bone marrow biopsy greater than 10% of the plasma cells defines the myeloma. Elevated total protein with normal albumin. Waldenstrom macroglobulinemia. This is the overproduction of IgM and malignant B cells. Patient present with lethargy, blurry vision, engorged blood vessels in the eye, and mucosal bleeding and Raynaud phenomena. Plasmapheresis is the treatment of choice. Bleeding disorders. One of the most important bleeding disorders, immune thrombocytopenia purpura, is isolated thrombocytopenia. Normal hematocrit, normal WBC, normal size spleen, diagnosed by antiplatelet antibody CT scan to exclude hypersplenism, and megakaryocytes are elevated. Von Willebrand disease, commonly seen in women, and decreased level of functioning of von Willebrand factor, and there is bleeding related to platelet epistaxis, gingival and gum. Von Willebrand antigen levels may be decreased, and astrocytin cofactor assay, factor 8 assay, and bleeding time is increased. Initial treatment is desmopressin. Hypercoagulable states. Thrombophilia. Most common cause is factor 5 laden mutation. Heparin-induced thrombocytopenia. Heparin-induced thrombocytopenia is more common with the use of unfractionated heparin. It is confirmed with ELISA. Stop all heparin and administer direct inhibitors like ergatoban. and lepidolin and bivalirudin. Warfarin should not be used first. Antiphospholipid syndrome. There are two main syndromes: lupus anticoagulant and anticardiolipin antibody. Both causes thrombosis. Treated with heparin and warfarin, and for DVT and pulmonary embolism. And antiphospholipid syndrome may require lifelong anticoagulation. Thank you.